about any of the specific topic, right? And in case if anyone asks that no, this was not clear, so we were returning back to that topic and then we were. Let's make it very clear that today we won't be able to go back, right? So once that topic is done, we'll move on to the other topic. Any suggestions, anything you want to say, you can let me know. Yes, I'll be using the same files. We'll be using the same files what was given to everyone. The same files which are present in our shared folder. USMLE we won't be touching at all today, because it will deviate. We'll be deviating from the topic. For USMLE, we'll be keeping one completely separate, different session. So we won't be talking about anything about the USMLE part today, or any of the competitive exam, or we won't be talking about any of the things like the study method or memory method, nothing, or the fitness, nothing. We'll be focusing purely on respiratory system. All those topics will be taken separately. All right, I think it's time to start. And yes, I'm recording it. So this recorded video, I'll put it into our shared folder. So you can download it from there. Let's start in the recording. All right, so this is respiratory system revision, and there would be 1 to 15 files. In the initial stages, we'll be talking about the basics, all the way basics to all the pathologies. Don't worry, this recorded video that will be put into our shared folder, right? Shared folder. In case if you are not having that link of that shared folder, this is tillrmbs@gmail.com. On this email address, you just send a mail to me and I'll send you the link. That is the link that is the Google Drive link. That is where all the files, including these files, plus the recorded video, I'll be putting it there. Files, so they are already there. I'll be putting this recorded part. Okay. All right. So from basics to all the way, we'll be talking about the pathological conditions. Right. So please pay full attention as we'll be going at a slightly higher speed. So here it is, respiratory system. When we talk about respiratory system, this is inspiration and the expiration. Right? These are the basic movements. For the respiration system, we need to understand that this is our brain. In brain, this is midbrain, pons, and the medulla oblongata. Right? These things will be coming in when we'll be discussing the brain in more detail. But remember this medulla oblongata, it is that part where the respiratory system is there. So this is the most susceptible system to hypoxia. Hypoxia means when there is less oxygen. So this is the center, which is our respiratory center. It is affected whenever the person gets a heart attack, right? So that means the blood is not getting pushed up. It is this center which is affected. So heart can start, but if this center is damaged, the person is like a vegetable, right? It is a vegetative state. All right. Two types of respiration. One which is called as the quiet respiration. The respiration right now which is going on in you and me right now. Right? We are not straining. We are just sitting. So that is the quiet inspiration, quiet expiration. Quiet inspiration, quiet expiration. Inspiration, this is where energy is used. Right? And in expiration, it is zero. zero energy. In ATP is the currency of our body. It is 100% passive. That means no energy is required for the normal expiration. So when we breathe in and then we breathe out, for breathe out, no energy is used. For exertional or the forceful inspiration and expiration, whether it is in or out, in both the cases, energy is used. That is quite obvious that in inspiration we are interested in oxygen, and in expiration we are throwing away the carbon dioxide. Onto the lungs. This is the basic layout. This is the right lung and the left lung. Heart is in between. Correct. So when the heart is on the right side, so that is called as the dextrocardia. So things will really look something like this, and you can watch this when we'll be watching certain X-rays. Right? And when all the organs on the opposite side, that means say liver is on the right side, stomach is on the left side. This is stomach, right? This is esophagus, right? This is stomach, this is duodenum. So they are all on the left side. When stomach goes on the right side and the liver comes on the left side, right? When everything is ulta, then it is all the organs are opposite. It is called as the situs inversus. Situs inversus. In anatomy, we will be talking about it in more detail, that why it really occurs when there is a defect in the rotation. Right? The whole thing rotates. Okay. So here it is. Aerobic is when there is oxygen. Anaerobic is when there is lack of oxygen. In lungs, that's our trachea, right? Then that trachea divides into primary bronchus, and then they divide into secondary, tertiary, and it keeps on dividing all the way till it reaches to the last part, and this is the alveoli. Here is the alveoli. So alveoli is a functioning, that is where the gas exchange will be occurring, right? And over here, these are the blood capillaries. These are the blood capillaries. So blood which is coming up, it is having large amount of carbon dioxide because it has come all the way from the body, right? It has come from the body, and then it is over here with the expectation of oxygen. So oxygen is given and the carbon dioxide is taken. This carbon dioxide is during the expiration, it is thrown out, right? And this oxygen it goes into the capillaries and it is carried to the rest of the body. So that thing continues. Over here, this was a complete circuit, right? We'll be calling it circuit. To make it a bit easier, let's do one thing. All right. That's the heart, right? This is the left atrium. This is the left ventricle. That is the mitral valve. Blood goes from here, left atrium to left ventricle. It goes to the aorta. From aorta, it will go into the entire body. This is the oxygen-rich blood. So oxygen is over here. Body will utilize it, right? Once it is utilized, this particular blood, it will come back into the right atrium. This is the tricuspid valve. From there, it will come to right ventricle. From right ventricle, this is what is called as the pulmonary trunk. Anything which is going out of the body, it is called as, out of the heart, it is called as the artery. So that's why this is also pulmonary artery. It is two, right pulmonary artery, and the left pulmonary artery. Right will go to right lung and left will go to left lung. Because they both are very near to the heart, so that's why this entire circuit is pulmonary artery. This entire circuit is very small, so that's why this is a low pressure circuit. So here it is. It will go to lungs. Right? In lungs, right, it will go to lungs. This is the blood which is carrying lots of carbon dioxide. Correct. This is what is called carrying carbon dioxide. Once it passes through the lung, it will come back via pulmonary veins. Right? Pulmonary veins. It will come into left atrium. Now it is having oxygen, and this oxygen-rich blood, it is circulating into the entire body. So that's how things go. So thus we are talking about two systems. One system, which is over here, which is related to the body, it is what is called as the systemic circulation. Right? Systemic circulation. and it is a high pressure system, high pressure. So the blood pressure which we are taking, right, when we say this is 120 over, say, 80 over 120, right, the diastolic and the systolic, right, systolic blood pressure. So these are the blood pressure which we are talking about. The lungs part, this is what is called as the pulmonary circulation. Lungs are extremely delicate, right? Alveoli, they are extremely delicate. So that's why this is a low pressure system, extremely low. I mean, even if it goes beyond 20 millimeter of mercury and we start shouting, this is pulmonary hypertension, right? Because when the hypertension, it increases, so we'll see that how it can lead to pleural effusion, how it can lead to pulmonary hypertension and so many complications, right? Okay, so that's how. So every time today when we'll be talking about the circuits, we'll be making it very clear that whether we are talking about systemic circulation or the pulmonary circulation. Right? Here it is, once again, the same thing. These are vena cava. Right? So the blood which is coming from the head and neck, so that will be coming via superior vena cava, and the blood which will be coming from abdomen and lower, right? So that will be called as the inferior vena cava. So here it is, the pulmonary trunk. This is the right ventricle. That's how it really goes. When we'll be looking at the anatomy, right ventricle, it goes to right pulmonary artery and the left pulmonary artery. And that's how, and then they'll be going into the respective lungs. The area from where these pulmonary arteries they'll be entering, this is the area which is called as the hilum. Hilum, right? That's called as the hilum. On to the respiration. The quiet respiration, right? In quiet respiration, that is normal what is happening, right? This is the inspiration, quiet inspiration, that is handled by diaphragm, right? This is the diaphragm. Diaphragm is that's the thorax, right? And this is the abdomen. So that's the thorax. This is the abdomen, right? And diaphragm is something which is sitting in between. Right? There are two domes, right and left. We'll see that thing in X-ray. But basically, this is the diaphragm, which is a muscle, right? No recording has started. It has started. I am recording it on my own hard drive, so don't worry. It's there. So this is thorax, this is abdomen, this is the diaphragm. Whenever you will be watching any of the X-rays, I say that this is the golden sentence. Watch all corners. This is where you'll be watching the date, you'll be watching the marker. That is whether it is right side, left side, you'll be many times getting the name, age, location, right? So, and especially when we say that those curly B lines, right, which will come later, right? But curly B lines, we saw that thing, right? So these are the points when we say watch all corners so that you don't miss anything. Okay. This was that what exactly is CT scan, right? CT scan is a cross section, as if you are cutting the body, right? And then you are watching that section. So this sectional, that's why it is called as the sectional radiography. It is called as the sectional radiography. Sectional radiography, that is possible in any of the plane, right? If this is the head, that's the nose. From the top, when we are into this plane, that is, it cuts like this, right? So that is what is called as the coronal plane. Coronal plane, right? When it goes like this, it divides it into right and left. So that is called as the sagittal plane, right? That is called as the sagittal plane. And when here is the entire body, right? This is the head, that's the trunk, right? So this is called as the transverse plane. So basically, it is x-axis, y-axis, and z-axis. Right? All those planes, they are possible. Oblique plane is, at times it is reconstructed, or if it is needed, then and then it is taken. Usually, oblique plane is not taken into CT scan. Okay. So inspiration, that is with the help of diaphragm, and the external intercostal muscles, they also take part into it. Moving on to how the ribs are attached. These are the ribs. On the back side, right, this is the posterior part. This is the posterior. This is sternum, which is anterior. So sternum is anterior, vertebrae, they are posterior. It is connected to the vertebra and the ribs. right? They will be connecting all the way from the back. We have got 12 ribs. Out of those 12 ribs, if this is the sternum, right? If this is the sternum, so then rib number 1 to 7, they will be landing all the way onto the sternum. Right? They will be landing onto the sternum. But the important point is that the anterior end of the rib, anterior end, right? So this means if this is the vertebra. So then the ribs, they are coming like this, right? So when they are coming like this anterior end, it is not landing directly on sternum, but there is a cartilage. But at least this is rib number 1. So then there is a cartilage of rib number 1, right? So that way it is landing straight away on the sternum. So when I say that rib number 1 to 7, they are landing on the sternum, that means right from the here all the way to the sternum, that circuit, that part is going all the way over here. Only thing, this much portion, this is cartilage. This much portion, right, it is cartilage. This occurs from 1 to 7. That's why we call them true ribs. 1 to 7, they are called as the true ribs. 8 to 10, rib number 8 to 10, they will be landing onto the cartilage of 7. That's how it will be formed. So, right, this is the reason that when we see the chest, so the ribs which are going like this, and then they will be going like this. Right? So this is what typical chest structure is formed. So 8 to 10, they land on costal cartilage of 7. Right? So they are called as the false ribs. 11 and 12, their anterior end is free. Right? Their anterior end is free, and that's why they are called as the floating ribs. In between the ribs, this is one rib, right? This is the second rib. So in between the ribs, there are muscles, and that's why they are called as the intercostal muscles. Costa means these are the ribs, right? So in between the costa, they are called as the intercostal muscles. So there are external intercostal, internal intercostal. We'll come to that. So here is the quiet inspiration. Quiet inspiration when we breathe in. So it is the external intercostal muscle and the diaphragm. They are into use, but for the expiration, right, muscles, they are just relaxed. Muscles use the energy only when there is contraction. Over here, they relax. So when they relax, air goes out. So that's why this is 100% passive. Lungs, they have got the tendency to collapse. So just see that why it is so. But basically, lungs, they have got tendency to collapse, and chest, it has got the tendency to expand. Right? And in order to do this thing, there are some factors which will be preventing the lungs to collapse and chest to unnecessarily expand. So everything remains into control. Okay. 2 movements, they are very much important. One, what is called as the pump handle movement. Pump handle movement means, here it is, this is that pump, right? This is that pump, right? When we just move it up and down, right, and the water comes, right? So that typical original pump, right? The pump handle. So this pump handle movement, its importance is that one end is fixed and the opposite end is going up. Right? Opposite end is going up. So the posterior part, it is fixed, and it is this anterior end which is moving. Right? Getting it? When this is happening, it means it will happen like that. When the sternum is low, as soon as it is lifted, it will increase the antero-posterior diameter. So here it is. This is the vertebra. Right? This is the vertebra over here, and that's the sternum. When it will move up, right? So then this sternum will go up, and then this antero-posterior, right? Anterior to posterior diameter, right? That length would increase. So that is, and the second one is that ribs, they all are arranged like this. So there would be this movement, and at the same time there will be this type of movement. Right? Classically, bucket handle. Right? The way this is the handle, if you take this handle up, so how it moves, right? Moves on the side and it goes up. right? So that is what is called as the bucket handle movement. So when there is bucket handle movement, there will be increase in the transverse diameter. I summarized it over here that there is increase in the AP diameter, right? When there is pump handle movement, increase in the transverse diameter when there is bucket handle movement, right? When it goes from both the sides. So that is the bucket handle movement. Quiet inspiration, right? Quiet inspiration, which is using the energy, which is using the muscles. So muscles contraction of diaphragm and the external intercostal muscle, that is where the energy is used. Quiet expiration, nothing is used. These muscles, they relax, and as such, the tendency of the lung is to collapse, so air automatically goes out, no energy used. In case of forced inspiration, we have got the sternocleidomastoid muscle. Sterno is sternum, cleido is clavicle, mastoid this is a process which is just behind your ears, right? Just behind your ears, if you feel, so that is the mastoid process, the muscle which is all the way going from the sternum, right? From the sternum and the clavicle. So this is from the root, and as it crosses, right, that is what is called as the sternocleidomastoid, one of the very important muscles. Then these are the muscles which are called as the scalene. Scalene muscles, they are anterior medius and the posterior. Scalene anterior, scalene medius, and scalene posterior. These are the deeper muscles which are on the side, right? So when you do forced inspiration, so you need to lift the whole chest. So understand it that way, that the head is fixed, but these two muscles, they will lift the whole chest, and that's how you breathe with forceful inspiration, right? So this is for that. When it comes to forceful expiration, right, it is the abdomen which comes into picture. So now we need to make the chest down, right? So it is the rectus abdominis which pulls it down, and then there are internal intercostal muscles. So rectus abdominis, this is a muscle. Rectus means straight. So this is that muscle, right? When we say six-pack abs, these are the abs. Everyone has got the six-pack abs because these are the tendinous intersections which are reflected when there is no fat or the less fat, they can be seen. All right. So this was our first part. Okay. Let's move on to the second file. Okay. On to the respiratory system part. So this was the second part. So thoracic wall, I need to change. So thoracic wall, right? Posteriorly thoracic part of vertebral column. So that is this. Anteriorly sternum and costal cartilage. Laterally ribs and intercostal space. Floor is the diaphragm, and the roof is suprapleural membrane. So that's how the entire chest is formed, right? And see, these were the cartilages what we were talking about. So diseases of thoracic viscera are the leading cause of death all over the world. That's why. And these two organs, lungs and heart, that's what we have taken them for. So clinical steps, history, inspection, palpation, percussion, and auscultation. And this is the method of discussion of any of the condition. Inspection is visual observation, and you just see it. Palpation is when you feel whether there is anything, say, abnormal, or if it is soft, it is hard, right? What we touch and feel. Percussion, right? Percussion is detecting densities by tapping. So when we did that when there is lung collapse, right? When there is air, there is no air, right? So then there is resonance. Thoracic viscera means organs, right? Over here, lungs and heart. And auscultation is what you listen via stethoscope, right? So here it is, right? Just same thing what we discussed. Important part is this. The visceral pleura, right? Visceral pleura and the parietal pleura. Visceral pleura and the parietal pleura. These are our lungs. Lungs are covered with one very specific layer, right? So we just use it that this is the pillow, and then cover of the pillow, right? Cover of the pillow. So that cover, and in between the space, in between the pillow and this cover, there is a space. Because pleura is exactly like that. Right? So here is the lung, and then there is a space around it. This is in which there is pleural fluid. Now, so pleura is that cover, right? And there are two parts. One is the visceral pleura, second is the parietal pleura. Parietal pleura, it is connected to the chest, correct? And the visceral pleura, it is connected to the lungs. So automatically there is a space in between, and this space is filled with a specific fluid which is called as the pleural fluid. The amount of this fluid is very less, 10 ml for both the lungs, right? It is that small. But as we can see that if you take one glass slide, you put just a drop of water, and then you put the second slide, right? Glass slide. So you'll find that they both will stick very firmly with each other. You have to actually peel it off to take them apart, right? Not very easy. Or you slide it sideways so that air enters. When the air enters, immediately it will be separated. So this is one of the best example, right? How the presence of small amount of fluid, it can keep both the layers together. Here exactly same thing is happening in this pleural space, right? Where this pleural fluid is present, this small amount of fluid is keeping both the things together. It is not allowing the lungs to collapse, and it is not allowing chest to go expanded unnecessarily. So it is keeping a check on both of them. Right? So these are some of the important landmarks. So here it is. This is the Mbbs, that's the sternum. This is the xiphoid process. Right? This one is the xiphoid process. And here are the up to 7 vertebra number, rib number 7. They are the 2 ribs, 8, 9, and 10. That's how they are landing. And here it is the rib number 11, rib number 12. They are floating ribs. And that is collectively the whole thing is called as the costal margin. Right? There are some lines, very, very simple. Right? This one, which is passing through the center of clavicle, it is called as the mid-clavicular line, and then there is anterior axillary line, and one which is passing right from the center, it is the mid-sternal line. On the posterior surface, we need to talk about this one specifically, inferior angle of scapula, because it can be felt very easily, right? And then the spine of scapula, even in yourself also, you will just feel, you just touch yourself and you'll be able to feel that spine of scapula. Clavicle, it is in front, very easy to palpate. So these are some important areas. Sternal angle, also called as the angle of Louis, right? It is this angle, sternal angle, right? It is the transverse ridge about 5 centimeters below suprasternal notch. So that is the suprasternal notch. You just take your hand down slightly and you'll be able to feel that very sharp ridge. It marks the manubriosternal joint, right? The joint between manubrium and sternum. That is where the second rib will be landing, right? So second rib will be landing. So obviously the costal cartilage of second rib. Right? This lies at the level we talked about it. Important. Sternal angle, this is very important. In fact, this question itself is very important. Right? You should really know it very well. So here we talked about it, that second costal cartilage will be landing at this layer. It marks the plane which separates the superior mediastinum from the inferior mediastinum. Mediastinum is nothing but, simply speaking, it is the space which is present between two lungs, right? Between two lungs. So that's our right lung, this is our left lung. So lungs, they have got their own area, but then there is a space in between. That is the space in which the heart is lying. There are other structures which are lying. Major vessels will be lying. Thoracic duct will be lying. Right? So all those things, they are present into that space. So chest is relatively very simple. There is one lung, there is second lung, and in between the space, what is called as the mediastinum. So this marks the plane which separates superior mediastinum from the inferior mediastinum. So this is that plane where the below is the heart and above is the all other structures. So it is at this level, right? It is the plane. Ascending aorta. Ascending aorta, this aorta which will be emerging from left ventricle, and as it comes out, it takes a turn, and then it goes once again down, right? So it goes up, that's why it is called as the ascending aorta. Then it takes turn, that's why it is called as the arch of aorta, and it goes down, it is called as the descending aorta. So the level, this level, right? It is the level of angle of Louis. So obviously, this is the arch of ascending aorta. So ascending aorta ends at this level. Arch of aorta begins and ends at this level. Yes, begins and ends at this level. And the descending aorta begins at this level. Right? Much So just quite easy. So these 3 points here. Trachea divides into 2 principal bronchi, right? So this is the trachea. When it divides, that's the level, right? Such an important level. Azygous vein arches over the root of the right lung and opens into superior vena cava. We'll see that, right? It will come. Pulmonary trunk divides into 2 pulmonary arteries just below this level. Pulmonary trunk, that's the pulmonary trunk, right? This pulmonary trunk, and then it divides and it goes to respective lungs. So that divides at this level, right? So that's the thing. Thoracic duct crosses from right to left side. And will be these are all the azygous vein and thoracic duct. They are part of the anatomy, right? So we'll see that thing into it. Marks the upper limit of the base of the heart, and the cardiac plexus are situated at this level. Plexus means group of nerves, right? So there are some important group of nerves. All these are like anatomy things, right? Okay. So that's how it really looks like. Here is the heart. Here is the heart, and from here, this is the arch of aorta, that's the anterior, this is the arch, and that's the posterior, right? So anterior, arch, and the posterior, and then it goes the descending. You must have noticed one thing, this anterior portion, right? This is anterior, this is posterior, right? So ascending aorta is anteriorly situated, even if you forget everything, but just remember this, anterior ascending, right, anteriorly situated is the ascending aorta, and the posterior is the descending aorta. It means arch is not like this, but arch is happening. That is the anterior, and this is the posterior. So it goes like this, right? That's how it goes back, right? So this is very important. This is a side view, and that side view is showing this is the anterior, this is the posterior, and see what happens, right? It is starting anteriorly, so that is the anterior mediastinum, and it goes back. Here is the spine. Here is the spine. So it is going all the way near the spine. So when you're taking the section, right, when you take the section, this is what was shown, this one, right? In the CT scan, we'll see that this is the vertebra, and near the vertebra, we'll be watching the descending aorta, right? Descending aorta. And ascending aorta, we'll be watching interiorly. When the section is taken at this level, we'll be really cutting the aorta at 2 levels. So we'll be able to see that. Here it is, the trachea, which trachea divides at 2 right and left principal bronchus. So here it is. Identification of trachea is C-shaped cartilaginous rings, especially when we'll be learning it into the histology, right? We'll see that the cross-section will be leading to this C-shaped cartilage, because we don't want that this particular tube should ever collapse, right? It should never collapse because it is the main supply of the air. Well, various angles, right, and their locations, right? This is more or less the anatomy part, but here it is the mediastinum, right lung, left lung, heart in between, superior mediastinum and inferior mediastinum, right? Mediastinum, the space which has been marked over here between 2 lungs. Rib number 1 to 7, true ribs, 8 to 10, they are false ribs, and 11 to 12 floating ribs. They are also known as vertebral ribs. And 8 to 10, they are called as the vertebrochondral ribs. Vertebrochondral. Chondral means cartilage, and this is the cartilage of 7th rib, right? They are the true ribs because they will be going all the way from vertebra to sternal, right? So that's why vertebrosternal, vertebrochondral, and the floating or the vertebral ribs. Least injured are rib 1 and 2 because they are protected by clavicle. They are pretty high, right? And rib 11 and 2 because they are free to swing. Anterior end is free. So usually you won't be finding any fracture associated with 11 and 12. The most prone ribs which are usually injured is 4, 5, 6, 7. Right? They are because they are snugly attached with the posterior end and the anterior end. So any of the impact, it can really break them. Right? Coverings of the thoracic wall, skin, superficial fascia, deep fascia, muscles. Right? These are the cutaneous nerves. Right? This is the anatomy parts. We are not right now touching it. So some of the muscles, important muscles, pectoralis major, pectoralis minor, these are the anterior chest muscles, right? Serratus anterior, serrations means like that RE, right? These are the serrations, Right? So these serratus anterior, these are the multiple strips of muscles which are covering the side. They are the side of the thoracic wall. Muscles of abdomen, they are actus abdominis and external oblique, which are forming the front. Muscles of the back, They are the trapezius. So these cuts, right? Those cuts, they are by the trapezius, right? Latissimus dorsi, it is this, right? That's the latissimus dorsi. So in anatomy, we used to call them traps and lats, right? So this is which is actually giving you the V shape, right? So levator scapulae, these are the levator scapulae, umbolus, major, minor. These are the muscles which will be elevating the scapula. Levator means elevate. So levator scapulae, right? So they are the muscles of back. Like serratus posterior, inferior, erector spine. Intrinsic muscles are external intercostal, internal intercostal in the transverse thoracic. They are the deepest. So we saw that internal intercostal, they are superficial. The external intercostal, they are superficial, and the internal one, they are the deep. Right? Transverse thoracic, they are the deepest. So here is how these transverse thoracic muscles they are arranged. Right? These are the intercostal muscles. Internal intercostal, then most superficial are the external intercostal. On the sides, right, these are the serratus anterior, right, and this one is your major muscle, that is the pectoralis major muscle. In this entire system, what we need to understand is only one thing. This is the rib, right? This is the rib. Just underneath the rib, right? This is the rib, just over here, right? Just underneath. Intercostal vein, artery, nerve, which we lovingly call as VAN, right? So vein, artery, nerve, they will be passing through this. This neurovascular bundle, when it is passing just underneath the rib, this thing should never be injured. So that's the reason whenever any of the needle is to be passed or any of the instrument is to be passed, it should never be passed below the rib. It should always be passing above the rib, right? Just remember this part, right? This entire katha, that was for this purpose. This is the correct way, so that you don't injure any of the vein, artery or nerve. Okay, so that is the vein, artery, nerve, and this is where we talked about that. This is the intercostal space, right? This is the intercostal space. So either you take it like that intercostal space, so the lower half of the intercostal space or the upper part of the rib is one and the same thing. This is the correct area, right? Remember just one concept, that it is vein, artery, nerve, they are just passing below the rib. But you should never touch that area. Okay. This was about the thoracic spine, right? This is more or less the anatomy part. We'll take that thing in neurology, right? All of them. Yeah. Even this part we'll discuss in coarctation of aorta, right? When we'll be discussing the coarctation of aorta, that what really happens in that case, it will come up. All these intercostal, then what is the drainage, how the intercostal veins they drain, mechanism of inspiration, respiration, right? So inspiration, volume of thoracic cavity increases, negative intrathoracic pressure, air sucked into the lungs. This is the basic thing, right? For the inspiration. So when the chest expands, so there is negative thoracic pressure, so air automatically comes in. So capacity of thorax increases in two ways, vertically, anteroposteriorly, and transversely. Vertical diameter, that is above, right? So that is what obvious. Right? The roof of the thorax, that is tough. It cannot move. This one, right? It cannot move, right? And I'm sorry, but say if you really don't know that what I'm teaching, then this is surprising. It has been said so many times that this is the respiratory system. So what to say? Right. So here it is the vertical diameter, right? Top to bottom. So this is the diaphragm. When we breathe in, diaphragm will go down. Right? Diaphragm is freely movable, so it is flattened. So thus lungs, they get the sufficient space to inflate. Did you join right now? Because anyone who has joined right from the beginning should not be having any problem. in understanding that we are talking about respiratory system. That's why we started right from the basic. So this is bad. Why you are 45 minutes late? Anyway, pay attention. So this is the AP diameter. AP diameter means anteroposterior diameter, anterior to posterior. That is when the ribs, they really move up like this, right? So that is what is called as the pump handle movement, right? So vertebrae are fixed, only the anterior end goes up. So that is the AP diameter is increased. That is the pump handle, right? So vertebrosternal ribs are involved, 1 to 7 true ribs. Just the examples. So AP diameter increase, pump handle movement. Transverse diameter, this is like bucket. From the sides, it goes up and down, right? So that is the bucket handle movement that it leads to increase in the transverse diameter. So these are the muscles, etc., which are involved, right? Expiration is a passive process because of the elastic recoil of alveoli of the lung. Because lungs, they tend to collapse. They like to collapse, right? So that is what is called as elastic recoil. Lungs would collapse. So that's when no energy is used. Muscles are relaxing. Intercostal muscle and diaphragm, they contracted. So now they are relaxing. So again, when they relax, no energy is used. There is increase in tone of the muscles of anterior abdominal wall. As such, anterior abdominal wall, right, that is also just contracting, so it will throw the air out. So that's why the expiration is a passive process. No energy used, right? No energy used. Types of quiet, deep, forceful. Right? In quiet respiration, the movements are normal. Deep inspiration, the movements are increased. First rib is elevated by scalene and the sternocleidomastoid, which we already talked about. Right? The muscles which will be pulling the whole thorax up. In forced respiration, all movements are exaggerated. The scapula is fixed and elevated by trapezius, levator, scapulae, rhomboides, major, minor, all those muscles, back muscles which we talked about. So posture of patient during asthmatic attack, breathlessness, difficulty in breathing, right? They will be most comfortable sitting up, leaning forward and fixing the arms on the table. So literally like this, right? They will be more comfortable like this. Diaphragm is set low so that lungs, they are getting more air. Then fixation of arm fixes the scapula so that it becomes for ribs. It becomes easy for the ribs to elevate. That was the second file. By the way, this is a good book, right? I can forward this book. The Secret of Writing Every Day, right? Everyone in the initial stages, maybe about 2 or 3 months back, I said that start writing. Do write, if not more, to at least 2 or 3 sentences every day. It will make a big impact on your even studies or even in your lifestyle. Right? You will be more accountable and you will be able to say accomplish much more. Okay, this is the respiratory system part 3. And if you are joining for the first time, keep this email address because that is the place, tillyouarmbbs@gmail.com. Because just send a mail to me, I'll send you the link. This is the place where all the files will be available. Not only that, the recording of today's session, right, that will be available. So you can just have a look at the initial part and be in tune. Right? So here it is, the quiet, active respiration, passive respiration, we talked about it. We talked about the mediastinum, supraemediastinum. This is the right lung, left lung, right? And the visceral pleura, parietal pleura. These are the layers which are covering. And in between space, it is what is called as the pleural space, right? That is the pleural fluid. Space between 2 lungs, that is the mediastinum. Right? That is the mediastinum, sorry. So that is the mediastinum. Right? This is what we talked about, the aorta going all the way from anterior to posterior. Right? There is intra-alveolar pressure, the pressure which is inside the alveoli Alveoli is that unit which is the functional unit of the lung, correct? So that is where the exchange occurs. Intrapleural pressure, this is between two layers of pleura, so that pressure we are interested in. And then there is a barometric pressure, barometric atmospheric pressure. This is the pressure which is outside pressure, right? So that's how things are arranged. And the fourth pressure, this is what is called as the transmural pressure of the alveoli, right? Or the transpulmonary pressure. So here it is, simply speaking, this is alveoli and this is the pleural pressure 1 and 2. Inside pressure minus outside pressure. So simply speaking, inside pressure is what? The pressure which is inside the alveoli. And 2, this is the intrapleural pressure, the outside pressure. Outside, who is there? That pleura, right? So that intrapleural pressure. So pressure number 1 minus pressure number 2. But obvious, if the inside pressure is more, right? Inside pressure is more, so it will expand. If the outside pressure is more, so it will collapse, correct? That's simple. So when we are doing it, intraalveolar pressure 1 minus 2, so that means if it is plus, that means intraalveolar pressure is more, things will inflate. If this is negative, that means intrapleural pressure is more, so it will deflate, right? So intrapleural pressure is always negative. This is negative because this is like a suction, right? It is like a suction. So this is chest, this is lung, and that's that pressure, this particular pressure between two layers of pleura is negative. So when the chest expands unnecessarily, the condition would be emphysema, right? When the lungs, they are going towards collapse, so that is what is called as atelectasis or the collapse of lung. Right? Both these things are prevented by the negative pressure because this negative pressure is holding both the sides, right? It is not allowing chest to expand, not allowing lungs to collapse. Then comes the transpulmonary pressure. So when we talked about 1 minus 2. So let's say the pressure in alveoli is 2 and this is minus. That's the point which you have to really understand. This is the minus pressure. So when it is the negative pressure, the total will always be plus, right? Total will always be plus. At this stage, right, I think you are right from the beginning. At this stage, if you are asking emphysema, that is very bad. How many times we have discussed emphysema? So 2 plus 1, this is 3. So this is 3. That means it will inflate, right? Emphysema is unnecessary expansion of the chest, right? When the chest becomes big, but respiration is not at all effective for the body. It will come in the path. Anyway, so here is the alveoli. This is 1, 2, and then there is a third pressure. The third pressure, which is outside one, right? This is the outside one. These are the ribs. These are the cut end of the ribs, and this is the atmospheric pressure outside. So here it is the transthoracic pressure. This is the pressure in the pleura minus atmospheric pressure. So this means transthoracic means we are talking about this particular pressure, this pressure, right? So the pressure which is outside, same way, 2 minus 3, right? 2 minus 3. Then we talked about the Casen's disease, but right now not needed. Remember it. The barometric atmospheric pressure is considered as 0, right? That is considered as 0. Transthoracic pressure, all the way, this is the pleura minus atmospheric pressure, pleura minus 0. So this is the pressure, right? The whole idea of this is that the pressure which is between the pleura, and the pressure which is between the pressure which is between the two layers of pleura, that is negative. That's right. That's right. So tension, pneumothorax. So when the air enters into this particular space, right, where an air enters into this particular space, this is the space that is where the pleural fluid is there. But if the air enters, so that is what is called as the pneumothorax. Pneumothorax, the topic which we'll be covering in tremendous detail with the X-rays. Trans-respiratory pressure, that is the intra-alveolar pressure, the pressure which is inside the alveoli and all the way to the atmospheric pressure, the full length, right? Full length. So lungs in resting state, chest. So lungs, they are like in resting state. They are more expanded, right? So the lungs try to collapse. Chest, that is in resting state, so that is less collapsed. So they will always try to expand. Here it is the compliance versus elastance. Very important point. Compliance is measure of stretchability, how much you can really stretch, that is compliance. And elastance is the ability to return, right? Elastic, right? Elastic, how much it can come back, that is called as elasticity. So ability to return, yes, something which is elastic, you stretch the rubber band and when you release it can come back easily, that is called as elastance. How much can you really stretch, that is called as the compliance. So all the tissues of our body, they follow these two principles very importantly. Because if you can stretch it, that means in context of this, lungs can really expand. You release it, lungs will go back to initial state, right? Any of these things is affected. So if you cannot stretch the lungs, that means lungs won't expand. If the lungs are not expanding, that means air is not going. If the air is not going, then gas exchange won't occur. Gas exchange won't occur, person will be having a difficulty in breathing, right? Simple. When the elasticity is less, so that means it can stretch, but it is not going back. Something what happens in emphysema. Chest becomes big, but it is useless because it cannot go back. It cannot go back. So whatever the air which has gone in, it cannot be pushed out. So that means even if the chest is big, but basically the gas exchange which should really occur, the air which should come in and out, that is not there. Right? So these are the two important things. When the tissue becomes thick, right? So there is decrease in the stretchability. When the tissue is thick, it cannot stretch. You cannot stretch it much. You take one rubber band, right, and then you stretch. You take 10 rubber bands together and then you try to stretch. You won't be able to stretch it more because thickness decreases the stretching. So similarly, any of the alveolar wall, if it becomes thick, it won't be able to stretch further. Right? Simple. So then we'll call it decreased compliance. Right? Decreased compliance. Elastance. Right? There is increased elastance. If the tissue is thick, it will come back immediately. Right? If it is thin, so then it will take time to come back because thick tissue, it will come back. So the point is that whenever we say that this compliance, there is increased volume at the same pressure. Correct? Compliance, same pressure, but when we say that compliance is more, that means it will be able to expand, right? It will be able to stretch. Elastance is equal to increased pressure for same volume, right? More pressure is needed to come back. So basically, compliance and elastance, they are inversely proportional. Obviously, right? Something which is stretching and elastance is coming back, so they are inversely proportional. This was about the radiology. Very quickly, I'll be taking a X-ray chest, PA view. PA means posterior anterior. This is the direction of X-ray beam. Direction of X-ray beam, that is, X-ray beam will be going from the back and will be coming from the out. Right, so that's considered. This is the patient. This is the nose of the patient. So this is the back side of the patient. Posterior. This is the anterior. X-ray beam is over here. The distance between both of them, right? This is the 6 feet distance and X-ray chest. AP view, when we say, then it will be completely reversed. The beam will be going from anterior and will be coming out from posterior. We will be taking such X-rays in case when the patient is bedridden or is in ICU. You cannot tell the patient, stand up and I want to take your X-ray. Right? This is for the diagnosis object, and you want, this was the basic principle about why we take this X-ray chest PA. So in PAV, this is, you want that object should be sharp and unmagnified. So that's the important part. So any structure which is near to the X-ray plate, this is the X-ray plate, right? This is the X-ray plate. Any of the structure which is near to the X-ray plate, that would remain into sharp and it will be unmagnified. Right? So here it is, we want that heart should be near to the X-ray plate. That's why we are taking a PA view. Right? So same way, if you want to take the X-ray of spine, so the spine should be near. Simply in that case, we'll be taking AP view. It is near. X-ray chest lateral view, right? We'll see that. So here this is how you see those X-rays, and this is the first thing which you'll see, the tracheal shadow. There is air into the trachea. See, air into the trachea, and that air can be easily seen. And this is the tracheal shadow because it will be telling whether there is right side or left side shift. Right? These are the anterior ends of the ribs. Right? Anterior ends of the ribs. So they are the anterior end of the ribs. We can't see all the way its attachment to the sternum because this is the area where there is costal cartilage, right? And the cartilage, you can't see them as clearly as the ribs because X-rays will be passing through it very easily. Right? So that's why they are not seen. Here is the air. This is the gastric bubble, and this entire opacity, right over here, complete everything is white. Right? This is because the liver is a big organ, quite tough, so X-rays are not passing through. So that's why we see this shadow over here. Right? This is the area of liver and the gastric bubble. Gastric bubble is stomach. Just for the practice. So this was our third part. Right. Let's move on to the fourth one. That was the respiratory system part 4. This is the email address. Right. For those for whom this is the first class, on this email, just send a mail, I'll send you the link. These are called as the generation. There are 23 generations, right, of this division. Trachea, the whole journey starts from trachea. That is the level 0, and then it keeps on dividing. So how it really divides? It divides into right and left primary bronchus. Those primary bronchus, they are dividing into secondary bronchus. They are dividing into tertiary bronchus, and they keep on dividing, right, all the way. So there are 23 levels, out of which first 7 layers, right? First 7, they are compressible. They are not compressible because of the presence of cartilage. Right? They are not compressible because of the presence of cartilage. So like trachea, right, primary bronchus, secondary bronchus, tertiary bronchus, they cannot be compressed because the cartilage is always there, so it is not allowing the whole tube to collapse. From 8th onwards, so last 16, they are compressible because they don't have any cartilage, and there is presence of smooth muscles. Now these smooth muscles, we know that these are the smooth muscles which are required for collapse and the dilatation, right? So because this is under the control of our autonomic nervous system. So there are neuroendocrine cells also present. They are called ZPUD or Ferreter or Kolchitsky. These are the name of the cells. So these 23 levels, right, first 16 levels, they are called as the dead space. Why dead space? Because this is the alveoli. If there is any of the artery which is associated with capillary, so then gas exchange can occur. So up to 16 levels, right, they are just dividing all the way so that the blood is supplied to the final, air is supplied to the final ends, right? So it is only into these last 7 levels that is where the gas exchange actually occurs, right? Very important concept. First 16 levels, they are dead space. That means over here, oxygen carbon dioxide exchange does not occur. No, right? No exchange. So they are called as dead space. Right. Over here, in these 7 layers, it occurs. So that's the explanation of the dead space, because they are just dividing, and there is no associated capillary. Okay. there is mucus, right? There is formation of mucus. And these mucus, this is to be thrown out, right? It has to be pushed out. So this is weak in last 6 levels, but otherwise it is present all over, right? So that this mucus is cleared, it is coming out. So when we talk about the cough, so that means this is khasi, right? Sputum, that is what really comes out, right? So sputum, there is a difference, because in patient, they say that yes, cough is coming out. So when they say cough, actually what they mean is the sputum. Right? So whenever you are writing the history, or whenever you are looking at any of the conditions, reading the book, so remember, cough is just khasi, right? Sputum is what comes out. Now we talk about the surfactant. Surfactant means this is that substance which is one of the most vital substances, because here is the alveoli. Inside this is the fluid, right? There is a fluid, and that fluid has got the surface tension, and this surface tension, it is making it to collapse, right? Collapse, because that's the reason that why it really collapses. So surfactant, it breaks the surface tension so that it will be preventing the collapse. So surfactant is released by these Clara cells present in middle or lower levels. Its synthesis starts in 20 weeks, intrauterine, right, when the baby is of 20 weeks. So 28 to 32 weeks, right, it starts appearing. Production starts from 20 weeks. So that's why there is a test called Clement test, or the lung maturity test. This is so important, because before that, even if the baby is say, premature, but baby won't be able to breathe. Baby won't be having any problem into the womb. The reason is that in any case, lungs are not working over there. Right? Lungs, they are into the amniotic fluid. They are just into the fluid, so they are not working. And that's the reason when we saw that fetal circulation, in which the blood really bypasses those lungs, right, with the help of that foramen ovale and the truncus arteriosus, in which that pulmonary artery to aorta bridge is formed, so that no blood it really goes into the lungs. Fetal circulation is coming up. So here it is the intrapleural pressure, which is the negative parietal pleura, and the visceral pleura, and this is the pressure, which is the negative pressure. So excess pleural fluid, that is drained by lymphatics. So the point is that the fluid which is present over here, it is not a dead fluid, right, which is always present. No, it is constantly, it is getting rotated. So the fluid which is secreted, and then it is taken out by the lymphatics. So here is intrathoracic pressure. So there are two procedures. One is called as the Muller's maneuver, and second is called as the Valsalva maneuver. Maneuver means actions. So Muller's maneuver is forced inspiratory effort with glottis closed, right? So you just close it as if you are trying to swallow something. You close it, and then you try to breathe, right? So that will lead to increased negative intrathoracic pressure. Negative intrathoracic pressure, that pressure is raised. But obviously, you are trying to do the inspiration, but you have expanded the chest and not letting the air go, so there will be the negative pressure. Correct. When it comes to forced expiratory effort with closed glottis, right, when you try to breathe out, right, when you try to breathe out, so that is when the chest is compressed, right, but the glottis is closed. So that's why there would be more pressure into the chest. So these are quiet inspiration. It starts at -5 to -7.5 millimeter of mercury, right? Quiet inspiration, very gradual, very slow. So when it is, say, -5, so if we take this is the intraalveolar pressure, 1.5, right? This is 1.5, and over here it is -5. So what would be the pressure, resultant pressure? 1.5 minus 1 minus 5. So minus becomes plus 6.5. This is more than, this is plus. So there will be inflation. It will dilate. When this pressure, when it is 1.5 minus 7.5, so that is also plus. So that's why it will never allow the alveoli to collapse. Right? It will just hold it. There is increase and decrease in pressure, but it is not becoming zero, so it won't allow the alveoli to collapse. The simplest of the example for all those doubts which were getting asked about the transmural pressure, etc. This is the basic which you have to remember. Till this pressure is negative, alveoli cannot collapse. Correct? Alveoli cannot collapse. So that's the most important thing, because all the pathologies they are associated with, given this particular pressure, it loses its negative pressure. So that's where, because the moment air goes, so this negative pressure goes away, and immediately you find that the alveoli starts getting collapsed, the lung starts getting collapsed. Right? So do remember this particular pressure. Right? It is always, it has to be negative. So this is same thing, P1 minus P2 plus the inflate minus the deflate. Right? And then all these calculations. Forceful inspiration, that is when the person yawns, right, or sigh, right? So that is forceful inspiration. Just a minute. Yeah. So forceful inspiration and the yawn and sigh, so that is the minus 30. And baby cry when at full strength, right? So then that pressure is minus 60. Muller's maneuver, when you do it, glot is closed, so there is more negative, so this is minus 100. All these things, they will be important from the clinical aspect, from the medicine. So right now, you just have to remember that Muller's maneuver, right? It is the inspiration, but your glot is closed, right? So that's the chest. Glot is closed, and then the chest is getting expanded because you are trying to do inspiration, but not letting the air go. So obviously, this will be more negative pressure, you know, because it is expanding, but nothing is going, so it becomes negative. And in expiration, that is when the person coughs or sneezes, right? So there is increased pressure, 30 to 50. Valsalva maneuver, when the person is trying to do expiration, right? Expiration, especially it is like when someone has got constipation, so what they do, right? So that will lead to this increased pressure, right? That's why at times it is said that anyone who has got the respiratory problem should not be having the constipation, because it will worsen it. These are the cells about the pneumocyte. Pneumo means air, cyte means cells. So these are the cells. These are the cells of lungs. Simple. Right? Type 1 cells, which are important, and they are big. Right? They are big. They are meant for the gas exchange, oxygen carbon dioxide exchange, and they cover almost 93% of the area. Big cells now, so almost they cover everything. These are the cell types 2. They are just 5%, but they are important from the point of view because they synthesize surfactant. Right? They synthesize surfactant. At birth, they are 100%. Right? Then gradually other cells they will start coming up, because these type 1 cell, they are not at all functioning when the baby is not born, because none of the gas exchange is going to occur. Type 3, just the 2%, they are the chemoreceptors. They are receptors. Receptors means those who are having, say, we talked about, right, receptors, that is, there is one stimulus and then there is effect inside. So these are the chemical receptors. Function of surfactant, decreased surface tension, that is one. It leads to increased distensibility and the decreased collapsibility, right? Because if the surface tension is there, it will collapse, right? So actually, this collapsibility, right, that is the characteristic of surface tension. So if you are decreasing the surface tension, so obviously it won't collapse, right? So that it has got ease of distension and it keeps the alveoli dry. Inspiration, start and end. So we have got the small alveoli, right, when the surface tension is decreased, right, and the compliance that would be increased, correct, when the surface tension is decreased. So compliance means ability to stretch, right, ability to stretch. So this was the ability to stretch. Previously, what was happening? Surface tension is trying to collapse it. So then bichara it is unable to expand because there is a collapsing force, the negative force that is more. So over here in the inspiration, so there is decrease in surface tension, there is increase in the compliance and the vice versa. This is the Laplace law, very important law. Laplace law physics, right? What it is telling is the tension which is present on the walls, it is directly proportional to presence pressure of its content into radius. Right? This is what is applied in all the medicine. So here, yes. So here it is the wall tension. How much tension onto the walls? Pressure into radius. So this is that wall tension, right, which is outside. So pressure, how much pressure it is getting exerted onto the walls, and what would be the radius? Balloon inflation, right? This is one of the example, right? When you do it, in order to understand this part, balloon inflation. You take a balloon and try to inflate it. Initially, you'll find that it is more difficult. Right? But once it starts expanding, then it will become much easier. The point over here is that it is the radius which is important. Right? So increase pressure when radius is small. When the balloon is small, so you blow at a more power, and then it starts getting expanded. So then you can decrease the power. So wall tension is P into R. So this is the pressure, right? And that's the radius, right? This is 2. So when we say wall tension is 8, so over here, when this radius is more, so yes, you can decrease the pressure, right? Easy. Because over here, this was the pressure into radius. So this is constant. So now, if one increases, second decreases. If one decreases, second increases. So that was the reason that when the value of R was small, right, when the radius was small, you were to exert more pressure. And when the radius starts increasing, so you have to exert less pressure to overcome this wall tension. Right? So that the atmospheric pressure is remaining the same. That balloon is to be inflated. So how much pressure you are putting, as the radius increases, the pressure decreases. So that's why initially you will be giving full force, and then it becomes easier. And when the balloon becomes this much, right, very comfortably you can blow air into that. So that's the same principle, right? Because final pressure, atmospheric pressure is going to remain same. Only that is to be overcome. Right? So keep this thing in mind: the radius and the pressure. So wall stress is pressure into radius upon thickness, right? We took it to next level, the wall stress. Size of all alveoli is same? No. Some alveoli are big, some are small, but as such, they are almost of the same size. Size of the alveoli, that is almost of the same size. Just but because it is the nature, that yes, it can happen like some of the alveoli, they are like this, or some of the alveoli, they might be like this, right? So they are like bunch of grapes. Literally, you can say like grapes, right? Bunch of grapes. So though the size of every grape is same, but it cannot be exactly the same. Same thing is true even for alveoli. Right? They're just the bunch of grapes. So you find that every grape, its arrangement is slightly different, but overall it looks like a bunch. Same thing. So wall stress is equal to pressure into radius upon double the thickness. Double the thickness. Double the thickness. That means if this alveoli wall becomes thick, that's where this trouble comes into picture. Let's say this is left ventricular hypertrophy, right? So the radius is now decreased. Why the radius is decreased? Because this is the muscle, right? The muscle has become bigger, left ventricular hypertrophy. Again, it will come in cardiology in more detail. So there is decreased wall stress, right? So there is pressure into radius. That radius gets decreased as the thickness increases, because we don't want that pressure, otherwise heart would blast. So we don't want that. Right? So what heart will do, as this thickness increases, right? As this thickness increases, it will drop the radius so that heart doesn't blast. Right? So why this heart, that lumen becomes small? Because lumen becomes small in order to decrease the wall stress. Here is the normal X-ray chest. BVM, they stand for bronchovascular markings. So usually outer 1/3, no bronchovascular markings. Here it is seen very beautifully, right over here. And if you see all the bronchovascular markings, they are up to this point. Beyond this, right over here, you are not finding any of the bronchovascular markings. Bronchovascular markings, these are these markings, right, which you see that like that shadow, like the way it is going. All these dividing. They are called as the bronchovascular marking. This is seen, right, very clearly. But it is seen up to outer 1/3. Right? Outer 1/3 has got no BVMs, and that is considered as normal. If present, then there is a problem. This is the X-ray of female, normal X-ray. When we see on X-ray anything which is white, right? Anything which is white, so that is the radio opaque. It is called as the radio opacity, radio opaque. When it is black, it is called as the radio lucent, right? It is called as the radio lucent. For CT, in CT scan, if you see anything white, it will be called as hyperdense, black hypodense. On ultrasound, anything which is white, it is called as hyperechoic, right? And black is hypoechoic. And in MRI, it is called as hyperintense, and this one will be called as black, will be called as hypointense. Talking about these two, that is where the radiation is used. Ultrasound, that is where the sound waves are used, and MRI, where the magnetism is used, ultramagnetism. So magnetism is used. Hilum is this part, right? Hilum is this part, right? Then whatever you are watching, all the way, all these are, right? That is bronchovascular markings, right? So now we talk about lung volumes, capacities, and some X-rays. So lung capacity plus volume. This will be extremely helpful in these two conditions, what is called as the obstructive versus restrictive lung conditions. Right? That is what we'll be watching. So the first thing which is coming up is our quiet breathing. The quiet breathing, the breath which is in and out. That means this is the inspiration, expiration. inspiration, expiration. So only a small amount of air is going in and out, and that is what is called as the tidal volume, 500 cc tidal volume. Then at the peak, right? So over here, after completion of normal inspiration and the extra air if we try to take, right? That is the deep inspiration. This is the deep inspiration. So when we try to fill our lungs to its capacity, this is what is called as the inspiratory reserve volume. This is the volume which we can really take in after normal inspiration. So that is about 3 liters, 300 cc. Right? And then that's the capacity. So how much, what is our total capacity of take the amount of air in? That is the tidal volume, which is a quiet inspiration. And then the forced inspiration, so that will be called as the inspiratory capacity. So this whole thing is the inspiratory capacity. So that's where there is maximum inspiration. Then again, we continue, right? We do the expiration and then normal inspiration, normal expiration, and then we go for forced expiration. Right, as much as we try to push out the air as much as possible, and at one point, yes, we are tired. Right, this is the amount of air what can be pushed, the maximum expiration what can be done, and this is what is called as the expiratory reserve volume. This is the reserve volume. Normally, we won't be using it, but the way it was the inspiratory reserve volume, same way now this one is the expiratory reserve volume, and that is about 1100 cc. Right. Even if we do the expiration and try to throw the entire air, but still some amount of air will always remain into our lungs because we can't throw the 100%, and that is what is called as the residual. Residual means bacha hua, whatever is left out. So that is called as the residual volume, which is about 1200 cc. Now the combination, this is one of the important factor, what is called as the FRC, or the functional residual capacity. This functional residual capacity is the total of expiratory reserve volume and the expiratory reserve volume and the residual volumes combination. So that is the FRC, right, or the functional residual capacity. This is quite obvious: respiratory resting inspiration and the respiratory expiration, right? So when the tidal volume normal which is going on, and that's the maximum expiration, and this one was the maximum inspiration. The total of all the way from top to bottom, right? Summation of everything. No wonder they'll be giving the name total lung capacity, right? So total lung capacity is inspiratory reserve volume. So this, right? Then the tidal volume, so this, and the expiratory reserve volume, this one, and the residual volume, this, right? So thus, that is the total lung capacity. In case of restrictive lung disease, there is trouble, right? There are two types of disease. One, what is called as the restrictive lung disease, and second is called as the obstructive lung disease. Restrictive lung disease means there is trouble inhaling, right? There is trouble inhaling. And in case of obstructive lung disease, there is trouble exhaling, right? Person will find it difficult to do the expiration. So what are some of the examples? This is like COPD, chronic obstructive pulmonary disease, in case of, say, emphysema. Now you know that emphysema, the chest is big, but because what is lost? Elastance, right? Elastance means the ability of the lung to compress, right? That is lost. So that lung is big, right? That lung is big, but it is unable to throw the air out. That is what happens in emphysema, right? In emphysema, there is loss of elastance. And that's why it is called as obstructive lung disease, because trouble is in exhaling, right? Or the chronic bronchitis, right? C is chronic, right? Something which is long-standing, chronic obstructive pulmonary disease. So this is the whole pattern. In obstructive pattern, there is problem in the exhaling, there is problem in the exhaling. So when there is problem with the exhaling, person is unable to throw the air out. That means the residual volume is left out. Right? There is more residual volume. The amount of air which is remaining present into the lung, that is more, right? Which is of no use. So that's a characteristic of obstructive pattern. If this is normal, right? The normal residual volume, expiratory reserve volume, tidal volume, and inspiratory reserve volume. So then restrictive pattern, right? That is when the amount of air which is going in is very less. So that's why you see the whole thing has become short, right? Emphysema cured by medicine depends. What's the status, right? What's the status? And then there are so many factors. Because COPD is not one thing. It is just a combination of so many things. We need to see the lung condition, what are the causes, then accordingly we can see whether it can be treated or not. So here it is the obstructive pattern. When we say COPD, chronic obstructive pulmonary disease, so it could be emphysema, chronic bronchitis, that is when there is inflammation. Now when there is inflammation, right? So that inflammation, itis is inflammation. So you give the medicines, anti-inflammatory antibiotics, so then they will treat. Right? In obstructive pattern, if there is asthma, then the treatment will be completely different. When there is bronchiectasis, right? This is another disease, bronchiectasis, stasis, right? Whenever we say stasis means stagnant, right? So there is permanent enlargement plus heavy mucus secretion. So sputum is there. There is so much of sputum, right? And it is a very foul smelling. So that is what is happening in this case. Cystic fibrosis, right? Cystic fibrosis. So this is a genetic disorder, right? This is a genetic disorder. And over here, the mucus plugs or clogs the pathway. That mucus, right? It will stop. It will get accumulated in between. So, air, it won't be able to go out. Right? See, the problem in all these cases is air is unable to go out. Right? So, whatever the air which is inside, it has been trapped. So, that is the whole idea in all these cases, whether it is COPD, chronic obstructive pulmonary disease, the lungs, they have failed to collapse. Right? So, that's why air is remaining over there. More of the residual volume or the asthma, or the bronchiectasis, in which there is heavy mucus secretion, and in cystic fibrosis, which is a genetic disorder. So the fluid-filled spaces, they are just obstructed. Against that, the restrictive pattern. Restrictive pattern means when the lungs, they have lost their ability to expand. So that means what has decreased? Compliance, right? Compliance is decreased. So why it occurs? There is fibrosis. And lungs, they have lost their, when person smokes. So then they say that lungs have become rigid. Rigid means what? Rigid means that they are unable to expand. If they are not expanding, so if the alveoli is not becoming big, so then that area which is used for gas exchange, that will remain less. Right? So that is pulmonary fibrosis. The way it is said that if someone is smoking since 3 years, right? 3 years. So then it would take 6 years of good habit to come back to the original state. Right? It is that bad. One, because it is getting recorded. And second, I'll reply to those emails in which some of you have asked about the smoking. Yes, it is always possible to quit smoking. Nothing is impossible. So I think that suffices the answer, but I'll write in more detail in email. I mean, is beer good? Why you want to take that? See, the thing is, for advertisement, right? Advertisement, they do all sorts of things. Right? They will do that. Yes, Bonvita is very good for the growth of children, etc. Right? What's the point? It is loaded with sugar. But no one would say give apple. No one would say that. So what we are writing means people say anything, but we know that what is good and what is bad. I mean, if someone tells that this much alcohol is not bad, etc. So I say that your such a big hand is there, right? So what if I demand that just give me this last digit, right? I'll give you 1 lakh rupees. Will anyone do that? No. So if you can't let your tip of the finger go, so then how can you really permit that, okay, whatever the alcohol is going, let it damage my liver, right? Because you are not watching it, not seeing it. No, don't try to do that. Don't try to change any of the friends. It is like everyone has got full and complete right to damage themselves, right? So just मैं तो इतना ही बोल रहा हूँ, you don't damage yourself, but that's it. बाकी for rest, it's entirely their choice. But don't damage yourself. Then second is this sarcoidosis. Sarcoidosis in which there is inflammation, and there is formation of granuloma, right? Granuloma. These are the clusters of cells which are formed, and that is what is called as SOL. SOL means space occupying lesion, right? So it occupies the space, and this is the space which is occupied, and it is not functioning anything. So unnecessarily it is affecting the body. Then comes the neuromuscular disorder. Neuromuscular disorder, there is muscular dystrophy, right? When there is muscular dystrophy, so then muscles themselves, they are not working. So how the person will be able to breathe? Because over here, what we are talking about is the restrictive pattern. Restrictive pattern means there is problem in the inhalation of the lungs, right? Then this is very bad. This is extreme obesity, hypoventilation. As your weight starts increasing, it is because of the abdominal fat, right? The amount of fat, visceral fat, which increases it, which pushes the diaphragm up. When the diaphragm is up, you will find that as the obesity increases, immediately their efficiency starts increasing. Right? Their efficiency goes down, and if you tell them to run, it becomes impossible for them. Right? That's the reason that extreme obesity leads to hypoventilation, because lungs are collapsed as the diaphragm goes up. Because neck is fixed, no? Neck is fixed. Whatever the space which is there, but only that much space is there. So neck is fixed, diaphragm is there, diaphragm is getting pushed. So now, no choice, right? This bichara lung, it cannot expand further, because niche to it is loaded with that visceral fat. This is what really happens, right? So that's why it's so important. Maximum inspiration, total lung capacity, right? Maximum inspiration, maximum expiration, right? So maximum inspiration, this is the total lung capacity, and maximum expiration this is at residual volume, right? These were the levels. Right? These are some very important levels that when we say that say quiet expiration, right? Quiet expiration, that is the level at which this is the resting level. Maximum expiration, that is the end of ERV, correct? And this is the maximum expiration, right? That we saw. That at the maximum expiration, you are at the level of residual volume, right? Because that's the distance. So once again, the same thing. So that was the total. Total our lung capacity is about 6 liters. Closing volume. So in apex, lungs, base of the lung, it closes first, right? Because air has got tendency to go up. So base of the lung, it closes first. That is the digestive system. Here are some of this is the, that's the breast shadow. This is a female, which is, I mean, this is the right side marker confirmed by the technician, right? So definitely it is there. This is the heart is on the opposite side. This is dextrocardia, but at the same time, you can watch the gastric bubble. So this is the classical case of situs inversus, right? Situs inversus, and it is because of the gut rotation, the problem in the gut rotation. We'll see that thing in embryology. Right? This was again confirmed by technician, mistake of technician, right? So this is not the left side, right? So this is the pseudo-dextrocardia when everything is fine, but so it was that. Right? And you can confirm it by auscultation. What you hear with the stethoscope, that is auscultation. Over here, this is the right-sided aortic arch displacing trachea, right? So this is sometimes the aortic arch, right? The aortic arch, which goes posteriorly. When it goes posteriorly, but what if it is slightly shifted on the right side? So that is when it will push the trachea, right? So here it is, you'll see the prominence, but see the trachea, it is classically, it is going like this, right? This, right? Got it? Now I'll remove this markings so that you can see it. Correct? All the way, here, 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 here. Correct? So that is right-sided aortic arch displacing trachea. And yes, because trachea is getting compressed, though it has got cartilage, but still if there is pressure, so then there will be, patient will be having dyspnea. Dyspnea is breathlessness. That's right. So here we are watching the extra ribs. That is what is called as the cervical rib. Right? See the cervical rib, the extra rib. So this is a very small rib, relatively. So you just see how big these are, right? And its location. So this is the cervical rib, and this cervical rib, from here the brachial plexus will be coming out, and this brachial plexus will be supplying the upper limb. So when these cervical ribs are there, so it will lead to compression of those cords, and that will lead to many of the complications. Over here, right? See, this is bifid rib. If you really see, this is like this. Bifid rib. Bifid rib is when the end, when the anterior end, right, it is a bit separated. It really doesn't matter, right? Over here, this is the bifid rib over here. Right? You can see that this is like this. See the normal ribs, they are going like this. This is the normal rib. This is the normal rib, right? But see, this one is the bifid rib. Can you see this? Here it is. The rib, one, and then it is like this, bifid rib. There is no clinical significance. It is just continue. This is just an accidental finding. All right. Over here, this is a very fine case, especially see over here. The ribs normally we watch till the anterior, but over here all the way, right? All the way we can watch it. So this is possible only when this occurs in aging. It occurs only when there is calcification, right? When there is calcification of chondral ends. Chondral means cartilage end, correct? Cartilage end. So there is a calcification. So you watch all the way till the end. All right. So this was the number 5. Let's stop at this point. We'll see once again. We'll resume this thing on our next session, and we'll try to and ribs expand in that situation. Well, you are right. There would be a problem, right? There would be a problem because it is when with aging, when the calcification occurs, it is not only the calcification, but even the joints, right? Even the joints, they will be developing so many osteophytes. So even the expansion would be difficult. This is the reason that as the age increases, they become more breathless, right? Because the muscles, they have become weaker. The movement, right? It's common in old people. That's right. That's what I'm telling. That their muscles are weak and the bone movements, they are not as smooth. And even the lung efficiency that decreases. So that's the reason. All these 3 reasons, they are for the decrease in their capacity. So obviously, we can't take the test on Tuesday. That's what I said right from the beginning, that we'll be shifting it. Lung capacity decreases. Their efficiency is almost same. Calcification. Say calcification is when the calcium is laid down. So say for example, this is the artery. When the calcium is there, that is called as the calcification. Right? Ossification is converted into bones. Right? These cartilage which were there, right? These cartilages, when they are converted into bones, it is called as ossification. So next Tuesday we'll be finishing rest of the files, and after that we'll be having the test. Right. Calcification is abnormal. So we have seen some of the X-rays in which there was aortic calcification. I'm telling that on Tuesday we'll revise, so on Thursday we'll be taking the test. Correct. Thursday. That is what these lectures are for. I mean, these are for physiology lectures. All right. So, thank you so much and take care. See you next time. Yeah, tell me, what's the question? Quickly, what's the question? Tachycardia in night? So many reasons. So many. Because we need to see this thing in reference with, are there any other condition? Because tachycardia can occur because of heart attack also, right? And it can occur because of the respiratory problem also. So many things. So there is no one reason. It's a big, you need to examine the patient. These are for revision. We have already finished all these topics. We have finished all these topics well in advance. Right? Now we are going for high-speed revision. Because there were 15 sessions and every session was over 1.5 hours. So obviously there was more than 20, almost 25 hours of material. So it was almost impossible to finish that thing in one session. And I never wanted to skip anything. Right? All right, so take care and wish you a happy weekend and see you next time.